Um, we are here today. Are our participants in? I'm looking to see as people are coming in. Excellent. People are coming in. We're going to go ahead and get started. Today's topic is going to be mental health awareness. I am Dr. Denna, Dr. Princess Denna, board certified internist as well as pediatrician. I'm here joined with my co-host, Dr. Delonda Harris.
Hi, thank you. I'm Dr. Harris, board certified in internal medicine, pediatrics, as well as obesity medicine. And I'm happy to be here. And we also have our guest, Dr. Megan Davis, which is a dear friend as well as colleague of ours. And she is double board certified in psychiatry as well as addiction medicine. Thank you so much for joining us again, Dr. Davis.
Happy to be
Yes.
here. Thank y'all for having me back.
Part two. Part two. Thank you. Thank you. Part one
Yeah.
was so good. We had to have another session.
Right.
Yes, it was. It was so nice to be with you guys. It's such good audience participation too.
Thank you. Thank you so much for coming back. Well, I'm gonna do some housekeeping before we begin. So a little bit of some disclaimers. Our sessions for our webinars are recorded. So what that means is by staying on this session, you are consenting for our recording, and we thank you in advance for your participation. Your participation means so much to us and to the community to help it to bring voices and conversation on this important health topic. On the bottom of your screen, number two, you will find something that says a Q&A for questions and answer, or you might see something that says chat. Please feel free to ask questions throughout this session. You do not have to wait until you're called on. Just ask questions. If you want to, you can ask questions anonymously. If you don't want to put your name there, that is absolutely okay that you do that as well. Number three, the information that we are providing is for educational purposes only. It is not a substitute for physical or mental health, right? It's for educational purposes. During our second and third portions of this webinar, we're going to be talking about very sensitive topics such as depression and anxiety and PTSD and suicidal ideations and what needs to happen. So if for any reason this is a trigger for you and you need to step away, take care of yourself. Feel free to absolutely do so. And if for any reasons you feel that you're in crisis and it triggers a crisis, or for you or a loved one, dial 911, or you can dial 988, the crisis center line, to have someone to talk to immediately. We wanted to make sure we say that for everyone that's watching. So thank you for joining us. Thank you so much. Dr. Davis, welcome back.
Hey. Thank you.
Well, I was researching mental health in Louisiana, and a lot of things came up that I don't think I was quite aware of. One of those things being that Louisiana ranks one of the lowest in regards to access to mental health in comparison across the country, right? And even with that, us knowing that if 1 in 5 adults have some form of mental health in Louisiana, greater than 50% of those individuals do not receive treatment or get any kind of treatment for their mental health. And, to start this off, can you talk a little bit about what is mental health, just to level the playing field for everyone? What is mental health and what does access mean?
Yes. So when I think about mental health, I always think about people living fulfilling lives. The health portion not being ill. We usually say mental health, and what we're thinking about is mental illness, having some sort of symptom that's impacting your life. But the health portion is having the ability to live your life, be with your family, do your job, and be fulfilled in doing those things and not having it negatively impacted by mental health symptoms or illness symptoms. Um, Access to care has been an ongoing issue really throughout the United States, but in Louisiana in particular, when we think about, there's a lot of areas in the state that are very, very rural.
Mm.
And so you're someplace more metropolitan, like New Orleans, Jefferson Parish, you may have much easier access to services as far as them just physically being there versus someone who's living in a more rural parish that maybe their closest access to care is 100 miles away, 50 miles away.
Mhm.
and that lowers their ability to get care, and creates a barrier to care. One of the things that has come out post COVID that has actually been super helpful is the increased availability of virtual visits. But
Mhm.
every doctor is going to be different. A lot of doctors want to see you in person for that first visit. And we are supposed to do at least one in-person visit a year, which again, if transportation is an issue or distance is an issue, that can create that barrier there. And then, of course, technology barriers. Some people are not comfortable using computers. So even though virtual visit is available, being able to log on or utilize your phone or have stable internet service, all those things create the barriers that we are really actively working to overcome. Louisiana is not well resourced.
Mhm.
Um, we do have inpatient care, but we do have really large gaps where there are other levels of care. Um, People can do partial hospitalization programs, which is going to an outpatient program. So I stay at home, but I'm still going in for care, usually 20 hours a week of care. So 4 hours a day, 5 days a week. I'm working with groups, I'm seeing a doctor. They also have what they call intensive outpatients, which is at least 9 hours a week, which is still a step down of care. One of the issues that we have here is that we have these programs, but accessing them is really difficult. There may only be one or two in your area. Of course, you can't really attend a job if you're participating in these programs. Some of them will have evening programming, like you can come after work from 5 to 8, but a lot of them are daytime programs. So if you have to be able to be off of work for it.
Mhm.
What's
Um,
the distinction between like the inpatient and the outpatient for the community who don't really know that? Like what is the distinction and when should someone consider inpatient versus outpatient?
So inpatient is I am living in this facility.
Yep.
I am here 24 hours a day. Most of the inpatient facilities in Louisiana are going to be locked facilities. So I can't decide to just leave. I have to
Right.
work with my doctor and make this decision together about when am I discharging. Versus an outpatient facility, which is I am making the choice to come here however frequently to interact with my doctor and my team of care providers here. Um, when we think about inpatient care, there is some criteria that we
Mhm.
usually think about, and I'm going to go through them. The first one is suicidal ideations. So someone who is seriously considering ending their life and they need to be acutely cared for and monitored for 24 hours a day. Someone who is homicidal, wanting to end somebody else's life. Homicidal due to psychiatric illness, so some
Right.
sort of loss of contact with reality. And they also need to be monitored more for the safety of the other person that they're considering harming. And then we have this category that a lot of people find confusing. It's called grave disability.
Right.
And that is where a lot of our patients fall. They don't have the first two, but grave disability, if I could just kind of do an overarching thought about grave disability, it's just that I no longer am able to care for myself. And it's showing up in an inability to find consistent food, consistent housing, my ability to take care of my medical conditions, including psychiatric conditions. Um, but and or that I'm at the point where I'm barely holding on. We do have a new caveat where if you are consistently treating someone and you're seeing that they are getting worse continuously, you can identify this as a grave disability and that we're right at that edge that they are no longer going to be able to care for themselves. So it's important for them to go in and be stabilized on an inpatient unit. So if you meet those criteria, it is best to go ahead and go to an inpatient facility and stay there for 24-hour care for however long is appropriate for your needs.
And can I make a distinction and please correct me when you said seriously considering suicidal ideation or suicidal attempts and seriously consider homicidal ideation, homicidal attempts. I think the distinction because in the outpatient setting when I see patients and I do the PHQ and I ask one of those questions in the PHQ-9, have you ever had any thoughts of hurting yourself? Sometimes I feel that patients might be concerned with saying yes just so that they don't get the doctors to say, "Oh, we need you to be admitted into the inpatient facility." And I think you use the word seriously, and I want to kind of flush that out a little bit because my understanding is that it also requires a plan. So it's not just that you're having suicidal thoughts, right, or homicidal thoughts, but you also have a plan, and that's what causes this it to be so serious. Am I correct?
You are mostly correct. Yes,
Okay.
very, very much so. So sometimes when we're evaluating someone, the severity of their depression is what really pushes us to hospitalize them, even if
Okay.
they don't actually have a suicidal plan. So it is always in context for what are the other symptoms and how severe are they.
Okay.
But when I think about just someone who's showing up and saying, well, I've
Right.
had these thoughts. I don't really plan on doing anything with them. I never have thought about doing anything with them.
Right.
And then I'm thinking, okay, you're probably more safe to go home.
Right.
Unfortunately, we do have some patients who have chronic suicidality, and this is just a part of their life. They're always considering ending their life, but
Right.
never doing anything to end their life.
Right.
Mhm, mhm, mhm.
But definitely, we take it in context, with how the patient's doing otherwise.
Excellent. Thank you. I didn't mean to interrupt you. Okay.
Oh, no, this is a perfect conversation.
Hey, and real quick, Dr. Davis, because I did just a little work inpatient. Can you expand on just the importance of collateral information? Because many
Mhm.
people, we talked about this last webinar, how many people may not realize how much of a problem it may have become, depression or anxiety. So just the importance of collateral, family and friends, and how you all may call them and weigh on them to get information.
Yes, we love to. And I always explain to patients when I'm asking for a family member or friend's phone number that I'm assuming this is one of your worst days. You are here, you're in the hospital with me. This cannot be how every day is. So I would like to get this additional information from your friends, your family members, so that I will have an idea of when are we getting closer to who you really are and who you are when you're doing better, even your best. Because I can't really assess that on a hospitalization when you're very ill.
Right.
And so when we call family, we ask a lot of questions. And sometimes family gets really nervous about that because they don't want to rat out their
Yeah.
family member. Um, and we really encourage people just to tell us the truth of the situation. They're already in the hospital. So it's
Right.
pretty obvious that they need some sort of care. Help us fine tune what else is going on around them. And honestly, sometimes collateral is also the thing that makes me say, maybe this person doesn't need to be here. Maybe this is more of a misunderstanding in between what they said in the ER to them getting here or what was happening at home and what the police said. Um, and that really can help us decide that no, this patient can go home sooner than later.
Thank
Mm.
you. Thank you. That's important.
Thank you. And you were shifting also to talk a little bit about the outpatient. So with the outpatients, the different options that are available, can you elaborate more on that?
Yes. So partial hospitalization programs are 20 hours a week. Um, Also outpatient. And so this is going to be one of your highest levels of outpatient care because you're going to be in contact with care providers for those hours, whether it's groups, whether it's actually doing individual sessions with a psychiatrist that's running this program, you're going to have this continuous care, but you still leave at the end of the day, go home, usually spend your weekends at home. Also, you have your intensive outpatients, 9 hours a week at least. And so there's that kind of that open space of you can be in an IOP that goes for 15 hours a week. It's still not a partial hospitalization program because it doesn't hit that threshold of hours.
Mm.
Um,
Okay.
but it can still be higher than those 9 hours. Usually, it's a lot of the same type of work that happens in the partial hospitalization program, just in a shorter amount of time. Um, and then you have just your standard outpatient doctor's visit where you would go in, see a psychiatrist or mental health nurse practitioner for usually a standard 20 to 30 minute visit, usually initial visits are a little longer, 45 minutes to an hour, because there's a little bit more to explore with those initial visits. Those usually happen based on the patient's need. So I have some patients that I see every 4 months. They're doing quite well, they're stable. We're just doing check-ins for their chronic illness. And then I have some people who I say, okay, I'm gonna talk to you in 2 weeks. I'll see you back in the office, or you may not need to come in the office. We'll do a virtual visit, but I need to keep a closer eye on you based on what we've discussed today.
Okay. Okay. And when they go into the outpatient setting, this is also a confusion to some patients. They're different, and you hinted on it too as well. There are different types of counselors or different types of providers that are providing care. Can we talk a little bit about the licensed professional counselors versus the psychiatrists versus the psychologists or clinical psychologists? Because all of them can provide therapy, but they all do something a little bit different. Can we make that distinction?
Yes, we definitely can. So your psychiatrist is a medical doctor. They've completed medical school. They've done a at least 4-year residency in general psychiatry. Hopefully you get to see a psychiatrist that's board certified. Um, And their focus in most cases is going to be medication management. We're talking about symptoms, what can we attack with medications, also identifying things that would not be adjusted by medications, and helping guide patients into where you can find more help for those issues because I don't have a medication that will touch on that problem. You then have your clinical psychologists. So they're a PhD level, so clinical psychologists. They're also doctors. You refer to them as a doctor. They have completed both most cases, a master's program, and then completed their PhD and done a 1-year clinical psychology internship where they have gotten additional training in providing therapy. And they're going to be your highest level of psychologist available. Louisiana is an interesting place in a lot of ways.
Yes.
There's
Yes.
only a, there's only a few states in the US, but Louisiana does have prescribing clinical psychologists.
Yes.
And so this is someone who has done all of the PhD work, gone back and gotten some additional training in medication management. And so you will occasionally bump into a prescribing clinical psychologist who will be able to both do your therapy and write your medications. You know, when we think about kind of who does what mostly, you usually think your psychiatrist is mostly medications, maybe a little therapy. Your psychologist is mostly therapy, and those with the additional training can do medications. Um, your licensed clinical
Social workers?
social workers, and your LCPs, like the clinical psychologists, they are usually completing a master's and some sort of additional training, but they are not going to get a terminal degree. Still provide excellent care. I'm very open about I'm in therapy. I've been in therapy for years because there's a lot of stress in taking care of other people and they're
Yeah.
taking care of their needs. And especially some of the more deep emotional needs that happen when you're a psychiatrist. And my therapist is a licensed clinical social worker,
Nice.
and I think he does an amazing job, is working with me. And he came highly recommended from another um, psychiatrist. So,
That's
Nice.
awesome. That's awesome. We all need help. We all need so.
I think
yes,
everyone
definitely.
should have someone to talk to, a counselor, therapist, everyone. I think absolutely. That should be like one of the checkoffs that every individual, once they hit a certain age, should have that as part of their toolbox, to be honest
Oh,
with you.
definitely. And really, when I was coming through residency for psychiatry, we were discussing the fact that previously psychiatrists also did a lot of therapy, prior to the pharmacology becoming the main part of what we were doing. 20, 30 years ago, they did a lot of therapy. And part of doing that therapy was also being in therapy for themselves. It's hard to be
Mm,
there for another person if you don't understand where your triggers are and what's your underlying
excellent point.
biases and the things that,
Wow.
are going to rattle your brain.
Right.
Excellent point. Wow. I never even thought about that. Excellent point. We have a question. Ito, you want to read that question? I saw your hands up.
Yeah, sure thing. First question from an anonymous attendee is how can we encourage someone who is suicidal to seek help?
Mm,
Yes. I think we had initially talked about going over this in a later portion of the talk, but we're going to go ahead and address it here. So, the urgency of someone when you're truly concerned about them harming themselves, first line, call 911. Call
mhm.
911 and say, hey, my sister is saying these things. I'm afraid she's going to end her life. Um, I don't ever want people to underplay the seriousness of someone voicing suicidal ideations, especially to a loved one, a family member. Even sometimes we'll, especially in this day and age, technology wise, we get lots of patients who have put posts on Facebook or
Mm,
Instagram. They TikTok a little video saying goodbye to people.
wow.
All of those are reasons. Go ahead and call 911. If someone's very depressed, then I'm always saying, okay, well, then you can maybe do something more about encouraging them to go into care, offering them rides, letting them hear what your concerns are about their health. But if we're at the point of I'm thinking they're going to end their life, I would go ahead and call 911. The other thing that you can do, which is a little slower of a process, but again, if someone absolutely needs care, there is something in Louisiana called an order of protective custody.
Okay.
You can go to your parish coroner's office and speak with a deputy coroner and explain to them what your concerns are about your friend or family member. They will print up an order of protective custody. You have to sign it, put your name on it, saying, hey, I'm standing by my concern. And this will give the authorities, unfortunately, the authorities in most parishes are the police, but it gives them the legal right to go pick this person up, bring them to a hospital for a psychiatric evaluation. Um, you know,
Can I say something too? And I think I want to bring this up because I think this comes up a lot when I talk to patients that the order of protective custody, it is not an arrest. It
it
is
is.
not a punishment. It is a safety tool. Like, so it's a safety tool to protect you and the community and the loved ones, your loved ones. So it's important that some people, when they hear the police is coming to get you, they think it's an arrest. It is not an arrest. I've had that conversation a lot with people. This is not an arrest. We are not punishing you for this. It's a safety tool. I'm sorry, I didn't mean to interrupt, but just wanted to bring that
Yes,
here because that comes up a lot. Mm,
it does. It comes up so much, even when people um, are leaving the hospital, they're confused about whether or not they were arrested. And I always am very upfront with people when you OCP an order of protective custody, um, a family member, yes, the police are going to come. In a lot of parishes for police safety, they do handcuff them.
mm,
And I know that that is jarring when what you want is for your family member to get help and then the police show up and they're putting them in handcuffs and they're putting them in the back of the car. That is for the police officer's safety. um and they will take them to the hospital. They're not taking them to jail, and they usually will be evaluated in the ER, and the decision is then whether or not this person is ill enough to be placed into an inpatient unit against their will, versus are there alternative ways that we could have them treated in the community that are reasonable at this point?
And I want us to evolve as a country because this isn't just in Louisiana how the police comes and take people to the hospital, but I want us to evolve in this country where they're coming with social workers or they're coming with a counselor, they're coming with someone so that they don't have to be handcuffed,
Right.
right? Because
Yes.
that sends a very different message in terms of it being for your own safety versus now I am in captivity,
Right.
right? And that itself can be a trigger. And I think that's part of the fear. And I want us to be open in this and talk about that too as well, that, and we haven't evolved. And I know in New York, if I'm correct, years ago, they were trying to move to us doing that, like trying to figure, could we get some social work with us for people who we know have mental health and who we're trying to bring to the hospital. And I hope that we're evolving just across the country. And I don't know if you know any initiatives or anything. Have you, I don't know.
Yes, so unfortunately, we did have services just like that locally for a while. Those funds, they're grant funded. Those funds, the grants run out, the funds get cut. But we did previously have services where a psychiatrist, a
Right.
social worker, and the police could all come at the same time. If the psychiatrist was able to interact with the person and thought it was appropriate, they could go ahead and put them under a short-term commitment and have them transferred. But the people who are care providers were side by side with the police. And that way we could go ahead and evaluate the situation
Mhm.
at that point versus someone now being transported away. And I have had some patients in the past who said, yeah, they showed up. I talked to them. They sat down. We talked for an hour and they decided that I was okay to stay at home.
That's
Or the psychiatrist wrote me some medications and told me to follow up with you, because I was in a crisis at 2 a.m. in the morning and Dr.
that's
Davis is not available. So, um,
good. That's good.
and so those services have been available. They are not consistently available locally, though, unfortunately.
Was that the ACT team? I remember hearing that.
So we do have ACT teams, which are separate. So ACT teams are assertive community treatment teams,
Mhm.
and those teams are for patients who've already been identified as having serious mental illnesses and needing consistent follow-up that is a little bit more out of the box, per se. So where the doctor, the nurse, usually the social worker, they come, no police is coming.
Okay.
They are coming as a team, and a good ACT team is worth their weight in gold because they provide the patients with medications. They can provide the patients with assistance in housing, some of those social services that a lot of people struggle to get. They can be there and they can help coordinate those services. But one of their main jobs is making sure that patients get their medications, have access to them. If someone's on a long-acting injection, they will bring it to them. You know, we always hear stories about excellent teams being like, hey, we brought you lunch
Mm,
and we brought you lunch and your shot.
Nice.
And, let's do this and make sure that we're keeping you as well as possible, doing our best to keep you out of the hospital. But it is slightly different because the routine work of a assertive community treatment team does not involve the police at all.
got it. Thanks for clarifying that for me.
Someone asked a question, and I think it's related to the OPC. Is this process safe for Black people? I'm just going to open it up. I
And
think that's an important
that's-
question. A very
It is
important.
It is a very important question, and I can say it really depends on who shows up at the door. And I can't
Mm,
say, and I do take that in mind when, we're advising family members to do an order of protective custody, that not all of them will end well. Patients who are resistant may be injured by the police on their way in. And that is not at all what we want. We are swaying the safety of the patient staying in the community long term versus the possibility of it being an unsafe transport to them getting to the hospital. And really, I can't do that math for the individual situations because I cannot say which police officer is going to show up.
yeah. Yeah. Hence why we need police officers, in my opinion, to also be trained in mental health awareness, to have sensitivity regarding that and how to approach patients with mental health. We need definitely more funding to be able to have resources for social workers and counselors and psychiatrists and psychologists to be part of this process. And I think the other part too is figuring out ways to encourage patients to self-report, right? So that they show up at the hospital so we can even eradicate the need for that transfer transport
Right.
to really
Yes.
happen in the first place. And I think a true fear and legitimate fear in the Black community is the mass incarceration, right? And knowing the numbers that a significant portion in prison system have mental health, and how sometimes these processes, even in the medical world, is weaponized against our community and our people. And I think that's a true conversation and reality that exists as well. And I always try to encourage my patients to self-report to the hospital, like try to, go to the hospital, have your family take you to the hospital and let the doctors make that assessment there at the hospital, if that's even a possibility, if that's even a reality.
Right. No, I agree. If people are willing to go on their own, you can cut out a lot of the transport issues, even the coroner's office, all of those things and you're there for care, which I do think everyone takes into consideration. Okay, this patient has some decent insight. They know something's wrong. So that helps me understand where could we go from here for their care.
Right.
Absolutely.
Right.
Ito,
Uh,
oh, sorry, Dr. Harris. No.
no, no, no. I was just looking at some of the Q&A, making sure we covered everything. One person also said it always seemed to take so long to see a doctor for my mental health problem, and that's a big deal. I think everywhere that's a big deal.
Yes.
Any quick advice on what we can do if we want to get in sooner, or where we should go? I know it. We talked about it. We'll talk about it later. But you also gave some resources where maybe people can self-report if it's taking too long.
Yes. So locally in the New Orleans area, there's Metropolitan Human Services District. And they do allow for some walk-ins, so patients can show up and say, "Hey, today I need care." And they will have them seen usually within a few hours, within their offices. And so they also have a lot of online services. So in preparation for this webinar, they also have their own crisis line, which I did not know existed. So they have a crisis line where you can talk to somebody in addition to 9888. That can be useful. That's on their website, but they have community clinics all throughout Orleans Parish. They also have some in Plaquemines Parish because that's part of this district for the state. In Jefferson Parish, you have Jefferson Parish Human Services Authority, or JPHSA, which also provides care for patients, uninsured, quick intake type care, so that you can be seen sooner. But yes, waits are very long, and it's surprising that frequently patients who have insurance have longer waits
Mhm.
than patients who have Medicaid or are uninsured, because of the different types of where services are being provided.
Mm. I didn't quite realize that. So patients with insurance wait longer, or probably even have to pay a lot more out of pocket because of deductibles and et cetera.
And deductibles, yes. And then it's with the insurance, frequently you're kind of siloed to like, I can only go to this set of doctors
Right.
versus I can go to this community clinic and there's 5 community clinics in this parish.
Good point.
That
Good
makes sense.
point.
And someone left a comment as well about Baton Rouge, where we're probably not too familiar because it's in Baton Rouge, but they said the Fisher Project through Care South calls every week during the crisis time,
Oh,
um,
nice.
for six
That's
months.
beautiful.
So the
This-
Fisher Project is in Baton Rouge if anyone's in that area.
That's so wonderful.
That's wonderful. What are some of so segueing into family members, so people being aware for family members, people being advocates, not just for themselves, but also for family members. What are some of the symptoms that someone who's not medically trained should look for to say, I think this person has depression, or I think this person might have anxiety disorder or PTSD? What are some of those symptoms?
So usually when I'm thinking about things that are somewhat alarming for depression, when people start to pull away,
Mhm.
being more withdrawn, isolative, when they seem to be losing interest, um, in things. So they had a hobby, they had a favorite restaurant, now they don't want to do any of those things. And if you're in the household with them and you're noticing significant changes in their sleep patterns, their appetite, weight changes that are unexplained, unintentional weight changes, usually those are the flags that I'm saying, hey, what's going on with you over here? Um, Anxiety, one of the ones that really is an external symptom for a lot of people is
Mhm.
irritability with anxiety. When someone just kind of seems to have gotten a short fuse real fast, when the first thing I'll ask, like, well, are you worried? Are you anxious? Is there something kind of that weighs on your mind mentally that has kind of gotten you a little short fused? Similarly, with anxiety, people do have some changes in energy, or they may seem to be more panicky and jumpy. Um, and so I started to ask more questions around that. PTSD is a little bit harder because you have to be aware of them having a trauma.
Mm.
And sometimes people are very quiet or uncomfortable discussing their traumas. But significant mood changes, avoidance, people pulling back also more withdrawn from their community, from their usual activities or things that I would say are red flags for asking more questions. What's going on with you?
Mhm.
Okay.
It's interesting. And real quick, I've called clinics to try to get appointments for patients with mental health, and they always say we want the patient to call themselves. But
Yeah.
sometimes, even with myself having mental illness, depression, I get that. But sometimes the lack of motivation, you don't have the desire to call yourself. You're just so like weighted that
Mhm.
it's like, can someone just help me make the phone call, bring me to the doctor? You just sometimes
Right, right. I need that support. This is where I need my
Mhm.
support.
hold and support, because if you had that motivation, sometimes you would have been had the
You would
appointment.
have called.
Right.
Right, right. Exactly. I would have been in care already.
Frustrating because it's like, wow, I need help, but like I gotta reach out for the help, but that's the problem. I'm too overwhelmed. So it's like it become a cycle to hold you from seeking the services that you need at that time. So just for family and friends, sometimes just handhold for a
Yeah.
little while. People may need that extra help and support.
Gentle
Yeah.
love.
Yeah.
Gentle love. It's time for our first giveaway. So we are giving away a diffuser with some aromatherapy because part of healing, we believe, comes with all of the senses, what we see, what we hear, what we smell, what we touch. So our first giveaway for today, I forgot to mention giveaways in the disclaimers earlier.
The combo was so good. We just started.
Oh, we just jumped in.
And our winner is number 3. We will find out who that is shortly. We'll find out who number 3 is that won the diffuser. All right. Um, Liz, do we have stats? Okay, let's move in. Interestingly, I want to kind of talk about something that I don't think we talk a lot about or are taught a lot about in primary care, which is substance abuse disorder. Because what we find is that people with depression or anxiety or PTSD might turn to substances, alcohol, tobacco, marijuana, etc., to alleviate some of those acute symptoms, right? And so how do we define substance abuse disorder, and how can a family member or an individual start to look at themselves to say, I might have a problem with this?
Yes. So with our substance use disorders, we do have diagnostic criteria from our manual. And you only have to have 2 out of 12 criteria in the past 12 months. And when I discuss this with people, I'm like, the bar is low, very low, if you're realistic with yourself. But most of the criteria is focused on how is this substance interfering with you living your life? Is it interfering with your health, your work, your relationships with your family and friends? Are you starting to use it in situations that are hazardous, thinking like drinking and driving? Even though I've also had patients who have been intoxicated and in their own homes decided, oh, I'm gonna change this light bulb and had a bad fall. That's still a hazardous situation. When you put it in the context of, you've now injured yourself.
Right.
Um, there's no number associated with it. And I always remind people of that there is no number. So for certain people, one drink is always too many. You
Mm.
cannot drink. It is always leading to something bad. Um, and when we want patients to review themselves, one, if you're starting to think about it, you probably do need to really think about it.
Mhm,
Um,
mhm, mhm.
because those regretful next days, not feeling well, those are signs that you're having physical issues related to your substance use. If you find that you're calling into work, showing up late because of your substance use, or you're not there for your family the way that you really would want to be. Those are all the signs. And then also the physiologic signs of substance use disorders, tolerance, which can be quite subtle. And tolerance is requiring more of the substance to have the same feeling. Um, and so it can be just, oh, I just wanted to have one more beer, or I took a half more of the pain pill. I usually take one, but I just took another half because didn't quite work as well this time. Um, and then withdrawal symptoms. If you're at the point of withdrawal symptoms, you probably need to be addressing it with your physician and seeking some additional care. So the withdrawal is if I don't continue to use the substance, I start to have physical symptoms. We know withdrawal from some of the anxiety medications, the benzodiazepines like Xanax, Ativans, Valiums, Klonopins. Withdrawal from them can be deadly.
Right.
And a lot of patients don't know that. I think this is a failure on us as physicians that we start these medications and we don't
Yes.
tell patients, hey, on the back end of this, in a year or two, you're probably going to be physically dependent on it and you will have a withdrawal syndrome if you stop it. Um, Same with alcohol. Alcohol withdrawal can be deadly. And those are ones that you definitely want to bring up to your doctor if you are having regular use of them and you feel like you want to stop or reduce your use.
Thank
Good,
you, Megan.
good point.
We
Um,
have a winner. That's what I was about to say. Tanisha Smothers. Yay,
Yay!
Tanisha.
Congratulations. We'll get your information and send out your diffuser. Congrats.
Perfect, perfect.
I want to segue. I know in interest of time, we're talking about adolescents. We talked a lot about adults,
Mm.
right? And some of these symptoms are very much the same with adolescents, but I think there's some peculiarity that occurs when we talk about mental health with adolescents. But in terms of withdrawal, in terms of acting out, so not necessarily the irritability that we will see with an adult who can confine it more, but getting into fights, right, in school, not performing well in school. So, how do we diagnose mental illness in our adolescent population? And what should parents or caregivers or teachers be looking for if we think that this is a possibility with this child?
So the criteria is usually the same, but with some caveats, like you're saying, your young child can't contain their irritability. So now they're fist fighting in school when they weren't doing that before. But some of the other things that we look out for, changes in grades, changes in behavior, both in school and home. So if an outgoing child stops being outgoing, starts pulling into themselves, and also a thought when I'm saying this out loud is that we think a lot about depression because it's so much more common, but also some of the signs of the initial symptoms of schizophrenia looks a lot like depression with that
Mm,
withdrawal, some of those cognitive losses, like people starting to just really struggle with concentration issues. Um, Changes in weight again, also body image issues. Sometimes our young adults are a little bit more open about disliking their body and wanting to make changes to it. But if that's kind of a new onset thing, um, self-injurious behavior does tend to be more common in our young
yeah.
adults. And so we do make a very big distinction between a self-injurious behavior, so young adults who cut their skin, burn their skin, um, usually cutting and burning is more common. There are some people who, however, are pickers. So they pick little holes in their skin, um, pulling out their hair, like patches of hair. All of that can be related to mood and anxiety symptoms. And it's not suicidal. They're not trying to end their life. They're usually trying to control a level of internal discomfort. Um, And this is also a group that is at high risk for initiating substance use, to help alleviate discomforts and to fit in, because there is some social pressures that happen that are more intense and people take it on a little bit more intensely at in these age groups. You know, when I'm thinking the age groups that I deal with, I'm an adult psychiatrist, but we do still get those transitional age adults, so people who are 18 to about 22, 23 still show up on our psych units and come to adult places for care. Um, and these are some of the symptoms that they would show up with.
And even with the self-harm, I want to throw in there too, hypersexuality as part of that self-harm too. So that internal stimuli in terms of feeling comforted. So some of my adolescent patients, that's a discussion we have is this hypersexuality so that they can get hugged or so that they can get that feeling of being soothed, right? And
Yes.
turn to that. That also is a sense of self-harm that I think a lot of people aren't aware of, even and then it could even take them into their adulthood too, as well, that a lot of people might not be aware of as well. And our adolescent population as they're moving more towards social media, right? Being a key thing. What we're seeing in America is that kids are having anxiety even at a younger age than they were 10 years ago because of social media and all of these things, the violence, sex, all of these things being thrown at them at such a young age and the impact that has on them as their brains are developing. So I'm not sure if you've seen that, Dr. Harris, in your primary care setting with some of the adolescents.
Oh, for sure, for sure. Social media is a big one. I was looking at a study and it said that passive social media is worse than or increases the risk of depression and anxiety compared to active social media. So passive social media is like just scrolling, just looking, because you start like comparing, like they have the perfect life, look what they're doing, they're tagged, they're out and about, living their best life. But active social media is a little better because that's when you connect with people. You're checking on people, you're making connections and staying in touch with family and friends compared to just looking at what other people are doing. So it's almost like if adolescents are going to use social media, even adults for that matter, it's almost healthier, if there's such a thing, to be active and engaged than to just spend hours and hours just looking, because you're absorbing everyone else's perfect life. And over time, that can take a toll on your anxiety or your depression if you feel like I'm not doing those things or I'm comparing myself to those people. So I thought that was very interesting. And it also mentioned more than 3 hours of social media increases the risk for depression and anxiety, which to me seems like a lot because I just have a lot, have a lot to do.
A lot of time.
But I guess if you think about kids in the summer, they have all day. You know, if they're not in school, they're not working, like they have all day to be on social media, snapping, taking pictures. But I think it definitely should be less than 3 hours. But if you're doing it more than 3 hours, you're at a very high risk for depression and anxiety. And
Wow.
social media is just taking over. So it also recommended taking breaks, sometimes even a week, just taking a break off of social media to just kind of rebalance and to just focus on self and to exercise or do more healthy ways of healing.
I like that. I like that. I like to have conversations with patients. I said, so what do you do when you're home? And they're like, oh, I'm on the phone. I said, besides the phone, like what else do you do? Nobody's playing hopscotch or jump rope or double dutch anymore. Like I'm like, nobody knows how to do double dutch.
Right, right,
So
right.
nobody's doing that anymore.
That's it. Because even families, if you go to restaurants or even at home, like everybody in the house, instead of talking, they'll be like just on their phone and they're sitting next to each other. And
That's a
we
problem.
have to work hard to not allow that to happen.
Yeah.
Yes.
To engage, to engage.
That's the
That's
word, to
important.
engage.
That
Active listening and engagement is so key, because it increases that social support that we're talking about, that family and friend bonding that we're talking about. Because when you're engaging, that's when maybe you can pick up, hey, they may be suffering. It seems like they're a little more depressed or they're withdrawing if you're engaging. But if you're not engaging, when do you pick those things up? You
Mm-hmm.
know, how do you tell, or you got to look on social media and say, they're ranting to the public. And it's like, maybe if we talked more, we would know that at home.
At home. Yeah. So I
Yes.
guess here's a question. So when are those opportunities? And I'm just thinking, just cases that I've seen. I told someone, I said, maybe don't, if you can, don't have the school bus pick up your kids. Maybe pick up the kids yourself, because that opportunity when you're driving them from home, I mean from school to home, is an opportunity for a discussion, just to talk to them. Instead of everybody eating at separate times, maybe have a time when everybody eats together, so that way that's an opportunity to say, how was your day? Let's talk about your day, even if it's just for 30 minutes. So what are those opportunities? What opportunities would you recommend, Dr. Davis?
I love the driving home because you're kind of trapped
Yep.
in a way,
Yep.
so we can have this conversation, and also you don't necessarily have to look in my eye while you're telling me something that
True.
maybe you're
True.
uncomfortable with. Over the meals, always excellent. Also, activities. We were listening to some research about how a shared activity. So,
Mhm.
we go for a family walk, or
Yep.
today is the day that we go to this particular restaurant or this park or do something together. And this is our family activity that we're doing together, is a time to both build that connection and also have those important conversations.
Thank you. I agree with you. Are there any other questions, Eton? Did you see any other questions? I see something that says,
Yeah. Can I go ahead?
yeah, go ahead. Mhm.
So I think there was a question about maybe if patients felt like they didn't want to betray the trust of someone who's struggling, um, how does one reconcile or go about um, asking for help on behalf of someone else?
Right. This is again the weighing the severity of the situation. Um, if I do not reach out, do I think this person is likely to harm themselves, harm somebody else? Will they continuously get ill and never get help? Um, and yes, it is very difficult. I mean, we were talking about collateral earlier, and a lot of times family members say, I'm going to tell you all of this, and I don't want any of it in the chart.
Mhm.
Um, because it's important and it's important for the doctor to know. But the idea that my family member knows that I told the doctor is just very jarring, because of course these are important relationships. We're talking about friends, family members, relationships that you would love to continue, but the importance of continuing them is like, well, you can't continue a relationship if they end up committing suicide. If they die by suicide, this relationship ends. Or if they're continuously getting worse and they're no longer able to be well enough to participate in these relationships, the relationship will end on its own in those ways. And especially when there's an opportunity to intervene, please take them. And I understand it's hard. I always understand that it's hard, but
It makes a difference. It saves a life. It saves a life. In the last
yes.
5 minutes, I want us to talk a little bit. I know we did for session one some of the medications, but if this is okay with you, because I do get patients that say, I don't want medicine. And I don't think people realize with depression and a lot of mental illness, there's a chemical imbalance, right? And the
Yes.
question is, how do we begin to balance that? And when we talk about toolbox and using our toolbox, medication is one of those toolbox, counseling is one of those toolboxes as well. Can you talk a little bit about not necessarily each medicine, but the benefit of medication? I know weight gain being something that triggers people. I don't want to get the medicine, but like just
Yeah.
some of the benefits of the medication and how to prevent some of the side effects that most people are worried about.
Yes. So most commonly we use medications called SSRIs, selective serotonin reuptake inhibitors. What they are doing is they're going to increase the serotonin in your brain. It's one of your brain chemicals highly associated with depression and anxiety. So increasing it does appear overall to help significantly reduce depression and anxiety symptoms. The nice thing about the vast majority of them is that the associated weight gain, it's roughly 5 pounds on the high end.
Mm,
And so when people say like, oh, it's associated with weight gain, yes, but where? We're not talking the 20, 30 pound weight gain that you might get with something like an antipsychotic type medication.
yeah.
We don't anticipate people to be very sedated because that's another concern that a lot of people say, well, I don't want to be drowsy and loopy and I have to be awake to take care of my kids. Most of these medications are not severely sedating. What do people do sometimes notice is that if their depression and anxiety have disrupted their sleep, when they are starting to be treated, their sleep gets better. Um, and
Mm.
they feel like, oh, this medicine makes me sleepy. And it's like, well, no, actually, we're just treating your disorder. And now your sleep is correcting itself. This is the sleep you should have been having for
Good
years.
point. Good
That's
point.
Um, and so we use these medications pretty freely because they're highly, highly safe. Most of them do not have a lot of important drug-drug interactions. So you can take them while taking your other medications safely. Most of them are safe even if you're having significant medical issues with your kidneys and liver. Um, and so we like to highlight their safety, and even for patients who are suicidal, because people worry about, okay, they have access to a new medication, maybe they're going to overdose. Most of these medications will not have significant harm in overdose. So even if you took the whole bottle, which no one's advising you to do, um, you are unlikely to have significant harm. You may be very sick, throw up, lots of diarrhea, but very rare for you to have like an actual overdose that causes you to die, or even the rarest risk is some
Serotonin.
changes in serotonin. Yeah, I was gonna say, how do I say serotonin syndrome without saying serotonin syndrome? Serotonin syndrome, which is where you have some issues with your vascular system and your body temperature. Even that is a very highly treatable condition, and very, very rare.
Excellent. Excellent. Thank you. Thank you for doing that. Let's do our last giveaway. Is that okay, Mia? Last giveaway. Let's see. She might be spinning the wheel.
okay.
Yay! Winner is number 4. And we will find out who that is. Last giveaway for our diffuser and aromatherapy eucalyptus.
Mhm.
Nice.
Eucalyptus.
It's such a lovely smell. I just like,
Oh, it is. It is. And lavender. But we have a winner, Tamor Urson.
Yay,
yay.
Tamara.
Yay.
Congratulations.
Congratulations, Tamor.
Dr. Davis, I want to thank you so, so, so much. This is for taking out of your time. This is the second time doing this with us. We so, so, so love you being here. I learn a lot from you every time I talk to you. So thank you for imparting knowledge to me as well as the community. We appreciate those individuals who took the time today to watch, to participate, to think, to listen. It's always a pleasure. And Dr. Harris, it's always a pleasure.
Thank you. Always. This was great. And
Yeah.
Dr. Davis, we're probably going to ask you again
I would love to come back.
at some
I
point. I'm not going to do it next month, but
yes.
because it's like she said, it's just amazing. I mean, we definitely learn a lot, and it's a great conversation, and it's so needed
Yeah.
because we all want mental health, not
Yeah.
mental illness, but mental health is
Yep.
so important for everyone.
Yeah.
And with that being said, definitely follow us on social media. Not too much, not 3 hours worth of social media, but we're on social media. So please follow us, like us, comment, just so that we can know what you want to hear, what the public wants to hear, and we can provide those services and that information for them. Also, we have a YouTube channel. Please subscribe to our YouTube channel where people can hear this webinar as well as previous webinars, just so that we can keep the conversation going for our community.
Thank you. Thank you, everyone. Have a
Thank you.
wonderful night. Thank you, Dr. Davis.
Thanks for having me.